This is Dr. Hessel recording the podcast on anesthesia for lung transplantation for the residents, PGY4 residents assigned to the cardiothoracic clinical rotation. The required reading is either the chapter in Hensley's book or the chapter in Preto's transplantation textbook, which will be sent to all of the residents. I've also called attention to other reading that might be helpful for you. End-stage pulmonary disease is one of the leading causes of morbidity and mortality. Unfortunately, there are many more potential recipients than lungs are available for transplantation, and it's been estimated that about a third of patients on the waiting list die. This shows the number of transplantations done worldwide through 2013. Note that the number has progressively increased and is now at about 4,000. This shows the number of adult lung transplantations by volume, and note that University of Kentucky with 20 transplants during the past year are among the more active centers in the world. There are four classic types of diseases for which lung transplants are done. These are divided in parenchymal versus vascular. The parenchymal includes obstructive disease, restrictive disease, and infectious disease, the latter mainly being cystic fibrosis. And the other category is vascular, which is mainly idiopathic pulmonary hypertension, but also left over from congenital heart disease. This shows the primary indication in the database worldwide. About 36% for COPD, 28% for diffuse parenchymal lung disease, about 19% for bronchiectasis, mainly cystic fibrosis, and about 4% for pulmonary hypertension. About 10% are for other reasons as listed on this slide. This gives a detailed breakdown of the indications for single and bilateral lung transplantation in the past 20 years. And this graphically displays the indications for lung transplantation over this same period of time. In general, the distribution has not changed too much, although the number for COPD has gone down somewhat, whereas the number for idiopathic pulmonary fibrosis has gone up substantially. This is related to the initiation of this lung allocation score, which took into the fact the expected survival without transplant versus the expected survival with transplant. Since patients with COPD tend to live longer without transplant, this has resulted in fewer of these patients given priority for transplant. This summarizes the indications and for lung transplantation, and this summarizes the contraindications, including the absolute contraindications and the relative contraindications. This expands on the guidelines for transplantation in COPD and the guidelines for transplantation for idiopathic pulmonary fibrosis. In the early days, most transplants were single lung transplants, and the reason for continuing to do this is to save donor lungs. It is primarily used nowadays for older patients with pulmonary fibrosis and sometimes emphysema. When done, they tend to replace the worst lung. If equal, then the left is preferred. It is not a good operation for pulmonary hypertension. Double lung transplant can be either en bloc or bilateral sequential, and almost all are done by bilateral sequential nowadays. This is preferred for most recipients because of a better long-term outcome. It is always chosen for infectious lung disease such as cystic fibrosis, and preferred for younger recipients with COPD or pulmonary artery hypertension. Heart-lung transplants are relatively uncommon nowadays, but in the pediatric group, living donated donor lobes are sometimes used. This illustrates the fact that the use of double lungs have markedly increased over the past few years. In 1993, about a third were double lung, while as in 2013, 3/4 were double lung. This shows the use of heart-lung transplants, which peaked in the 1990s and has progressively declined since that time. Of great importance are the donor lungs. This slide shows the so-called absolute criteria, the ideal criteria, and the extended criteria. Donor lungs traditionally came from brain-dead donors, but more and more are being used from DCD, so-called death after cardiac arrest. There's important size matching. One cannot put too large a lung in a patient, although this can be tolerated for single lung transplantation. ABO matching is required. The donor lungs are typically preserved by first flushing them with large volume of hypothermic perfusion, often then inflating them with 50% oxygen and storing them at 4 degrees temperature. The accepted cold ischemic limit is somewhere between 6 and 8 hours, and the warm ischemia, i.e. the time that the lungs aren't cold, such as during implantation, it's ideal that this be less than 30 minutes and a maximum of 60 minutes. A new introduction method as ex vivo lung perfusion. The purposes are to recondition the lung and assess its function. It is perfused with a lung protective acellular perfusate at normal thermia. It's not yet used at University of Kentucky, but in a significant number of cases in Toronto. This shows the circuit used for perfusing the lung, and this shows a lung inside a chamber being perfused. In the supplemental references, I've provided details about the outcome of this procedure. The anesthetic management is highly influenced by surgeons' preferences. It may vary from case to case, and therefore it's important to ask the surgeon about their plans, especially regarding whether they anticipate use of cardiopulmonary bypass and whether they want a single or double lumen tube. This summarizes the various stages in the anesthetic management of these patients, beginning with the pre-op evaluation, room setup, induction, one lung ventilation, dissection, insertion of the lung, reperfusion, resuming perfusion, closing, transport, and postoperative care. At the time of the preoperative visit, it's important to review the patient's initial transplant workup and to determine if there have been any interval changes highlighted on this list. You will obtain a repeat CBC, CMP type and cross-match, conduct an airway examination, and note the SpO2. These labs are often ordered by the transplant coordinators. The patient's oxygen needs to be monitored. One might consider cautious administration of anxiolytics, but they need to be placed on nasal oxygen at this time. If they have history of GERD or recent oral intake, then you need to use usual procedures to minimize that risk. Start a peripheral IV and an arterial line, and in some patients, an introducer. Some places place a preoperative thoracic epidural, but that's usually not done at University of Kentucky. This is the pre-workup done at Toronto General Hospital, and this summarizes the operating room setup used at Toronto General Hospital. On this slide, I have listed the drugs and the infusions and other equipment that needs to be set up in the operating room. This lists the preoperative medications that are currently used, including the antimicrobials and the anti-rejection medicines. These are typically ordered by the transplant coordinators on the transplant service. This details the technique for ordering, preparation, and retrieval of these drugs currently in practice at our hospital. As I indicated, the arterial line is usually placed pre-induction, usually radials. Dr. Shafi has some reservations about brachials. An internal jugular MAC introducer with a PA catheter is usually placed post-induction, but consider placing pre-induction in patients at high risk of decompensation at induction, such as those with severe pulmonary hypertension. It should be inserted on the side of the transplant or the right IJ for double transplants. If done while awake, the patient must be sitting up and one must beware of air embolization. I also recommend use of the BIS, cerebral exometry, and every patient should have a TEE. The anesthesia is typically narcotic-based, with the surgeon and perfusionist with a standby heart-lung machine should be in the room prior to induction. Usually a rapid sequence induction with succinylcholine, etomidate, fentanyl, and rocuronium subsequently. Maintenance is moderate dose fentanyl, low dose inhalation, anxiolytic if thought necessary, muscle relaxants as needed. For positioning with single lung, typically they're placed laterally with a groin accessible for cannulation for possible cardiopulmonary bypass. For double lung, usually they have a bilateral transsternal lower anterior thoracotomies called the clamshell, and they're in the supine position. There are several options for the arms as summarized here, either extended above the head, arms tucked at the side, or arms out at 90 degrees. This shows the placement of the arms above the neck and head, which I think Dr. Skella uses at the present time. As far as management and complications, it's highly influenced by the primary type of disease. In this summary is provided the disease-specific anesthetic complications. And on the next few slides, I've summarized the anesthetic management of these patients according to their primary disease. All of these patients have limited cardiovascular reserve, are prone to cardiovascular collapse during induction. Thus, you have to have the surgeon and perfusionist in the room. They require prolonged pre-nitrogenation and a narcotic-based induction with early gentle assisted ventilation to combat hypoxia and hypercarbia. For obstructive lung disease, there is high risk of air trapping, and management is outlined here. For restrictive lung disease, they may require very high ventilation pressures, even up to 40 centimeters of water. For suppurative lung disease, the main problem is secretions in the lung, and therefore one may start with a single lumen tube to perform vigorous tracheal toilet using an adult fiber optic bronchoscope. They may also require high ventilatory pressures and frequent tracheal toilet during the procedure. The most difficult patients are those with pulmonary vascular disease. They are highest risk of cardiovascular collapse. They are often candidates for pre-op pulmonary artery catheter. The surgeon may elect to place femoral vein and artery wires to facilitate emergent VA ECMO. If they are on pre-op IV vasodilators, these should be continued, and one might consider starting inhaled nitric oxide. I've listed the therapeutic goals, the drugs of choice for induction, and the vasopressors of choice. The surgeon may elect to use cardiopulmonary bypass or ECMO prior to pulmonary artery clamping in these patients with severe pulmonary hypertension. This summarizes ventilatory management of these patients, but it must be individualized as we've just summarized. On this slide, I've summarized their fluid management, which follows the guidelines for most thoracic surgery. I think use of TEE to help guide therapy and the use of respiratory variation of arterial pressure, stroke volume, such as the FlowTrack, may be helpful. It is likely better to use vasoconstrictors instead of administering excessive fluid loading. Tend to keep the hematocrit over 25, and after transplantation, Dr. Shafi likes to see a brisk urine output. We've talked about lung isolation. If cardiopulmonary bypass is planned, then one can use a large single lumen tube. If cardiopulmonary bypass is not planned, then use of a double lumen tube, usually a left, even for left-sided single lumen transplants. As I mentioned, if they have purulent lung disease, you may start out with a single lumen tube, and if you're doing a rapid single sequence induction and placement of the double lumen tube is problematic, then you may start with a single lumen tube and then convert to a double lumen. In all cases, discuss the type of intubation with the surgeon. A perioperative TEE is essential in these patients, and these are nicely reviewed by an article co-written by Dr. Dwarakanath of our department. And on this slide, I've summarized what the pre-transplant examination consists of, the examination during the procedure, and the examination immediately post-transplant in the operating room. The surgical sequence is usually, if it's a double lung, to do the worst lung first. If it's a single lung, they tend to prefer to use the left lung if possible. During implantation, typically first the bronchial, followed by the pulmonary artery, and then the pulmonary vein anastomosis. However, this may vary from surgeon to surgeon. The surgeon may release the pulmonary artery with the pulmonary vein still open to wash out preservatives and de-air, and then it's closed and perfusion is resumed. There are many critical times during transplantation, and these times are outlined on this slide. Patient with severe end-stage lung disease may experience profound hypotension following induction and initiation of positive pressure ventilation for the reasons outlined on this slide. Another problem is management of pulmonary hypertension, which we've already discussed and also summarized on this slide. Cardiopulmonary bypass is used in between 15 and 40% of patients and varies widely from case to case and surgeon to surgeon. It may be used electively or for problems during the case. On this slide, I've summarized the advantages and disadvantages of use of cardiopulmonary bypass. In any case, one must always be prepared for the possibility by obtaining a baseline ACT, having heparin available, and an antifibrinolytic available. Cannulation may be either central from the right atrium to the ascending aorta or peripheral from femoral vein to femoral artery. Some favor use of VA ECMO instead of cardiopulmonary bypass, and some of the recipients may come on ECMO, which may be used during the transplant procedure. During the period of dissection of the recipient lung, there is risk of bleeding and hemodynamic and ventilation compromise due to compression on the lung or heart. Thus, one must carefully monitor for hemodynamic, ventilation, and airway pressures, obtain frequent blood gas, and watch for and replace significant blood loss. The cross-clamping of the pulmonary artery is a time of potential problems. Before clamping, the pulmonary artery catheter should be withdrawn into the right ventricle. Clamping may reduce the shunt and improve oxygenation, but may result in severe pulmonary hypertension, right ventricular failure, and systemic hypotension. I have outlined some of the management options in these patients if confronted by exorbitant hypertension or hypoxia, pulmonary hypertension, systemic hypotension, or hypoxia at this time. While they are implanting the new lung, the surgeon will try to keep the lung cold with topical ice and fluid. They may compress the heart and lung and cause hemodynamic compromise, and they may have continued blood loss. Reperfusion is another important time. Patients are given methylprednisolone prior to perfusion of each lung. The surgeon will release the PA with the pulmonary vein still open to wash out preservative and air, and then close it and gradually release the pulmonary artery clamp to resume perfusion. The surgeon may request bronchoscopic evaluation of the anastomosis and suctioning of secretions before resuming ventilation. And as I mentioned before, there may be considerable blood loss at this time. The surgeon will give instructions regarding how to re-expand FiO2, peak airway pressures, tidal volume, and PEEP. Often the patients become hypotensive when reperfusion is initiated for various reasons. And then, as mentioned before, TEE inspection of the anastomoses must be conducted. Post-implant, lung protective ventilation strategies are employed. Ischemia reperfusion injury can occur anytime in the first 72 hours, starting immediately post-op. This is thought to relate to lung preservation and ischemia, and I've pointed to a review article that might be helpful. Some of the manifestations are reduced PF ratio, reduced compliance, appearance of an infiltrate, and increased pulmonary vascular resistance and pressure. And I've summarized some of our therapeutic options. The degree of reperfusion injury has been classified by the international organizations as outlined on this slide. After implant, there may be continued bleeding, and therefore it's important to obtain appropriate diagnostic studies and have blood products available. At the end of the case, you should change the double lumen to a single lumen, insert an OG or NG tube, conduct bronchoscopy to examine the anastomosis, to re-examine the anastomosis, and apply thorough tracheal toilet. Dr. Shafi prefers transferring on an ICU ventilator with inhaled nitric oxide and TIVA as needed. End-tidal CO2 monitoring should begin in the ICU, and one should plan for early extubation if possible. There are a number of postoperative problems as summarized on this slide. These are some of the later complications, which I won't discuss in any further detail, other than a brief comment on immune suppression. These have three phases: induction, maintenance, and treatment rejection. It varies greatly among institutions. The traditional agents are listed. What we currently use for induction here is bacillamide, mycophenolate or Celsup, and methylprednisolone. The results are nicely summarized from the world's data from the International Society of Heart and Lung Transplantation. This is the latest information, which gives the results through 2014. I should say 2013. This briefly summarizes the survival for those done between 1990 and 98, and those done between 1999 and 2030 from the International Transplant Organization. On the left side, I've summarized from a review article that appeared in JAMA 6 years ago. The median survival currently is about 5.7 years, and if one survives 1 year, their median survival is almost 8 years. The next slides give a detailed analysis of these results.